We'll hopefully get into that next time. All right, let's go ahead and finish up with the pharmacology. So we'll start off with steroids. And for those of you who don't know, I gave a lecture back in 2019 to the IE talking specifically about kind of what we've covered so far with the patients who are more prone to having issues. And what everybody took away is that I'm the guy who gives steroids to everybody. And I had more questions than any other presenter because they were all so worried about steroids. I don't know why, but they were. And when you actually look at steroids, the reason they're so impactful is going back to this scary looking diagram. NSAIDs are going to work on your COX enzymes right here. Steroids actually work up higher on this phospholipase A. But as the membrane lipids have the damage and get turned into arachidonic acid, the corticosteroid will actually stop that. So it works higher up than NSAIDs, and it's a much more effective drug because of that. Now, these are not the Arnold Schwarzenegger pump you up steroids. They are really potent anti-inflammatories. And I always like to tell patients that because oftentimes they'll be like, oh, I don't want to have a steroid. I don't want to look like Arnold. And really the thing that it comes down to is there's a huge difference between short-term dosing and long-term dosing. And did you guys learn that there were a lot of side effects with steroids when you were in dental school? Does that sound familiar to everybody? Yeah? No? Cool. Most of those side effects are long-term. And what we tend to see in the short term is they may be a little hungrier, they may have some mood changes, they might have some difficulty sleeping. So one of the really important things is if you're giving them steroids, they don't take it at bed. They take it in the morning. So if you're seeing an emergency patient at 4:30 in the afternoon, you tell them to take the steroids starting tomorrow, because otherwise they're not going to sleep through the night. And if they are a diabetic and they're checking their sugars, you may see a 5 to 7 point increase, nothing excessive. Just let them know they may want to check their sugars a little bit more closely, and if they have to adjust their insulin, kind of go from there. There's some debate as to whether or not, the steroids, they will decrease the immune system. And some people are worried that it may cause issues with infections. So if that's the case, give it with an antibiotic. But for the amount that we're giving and the short-term dose of it, it really isn't a big deal. We have two main steroids that we're going to give. We're either going to give methylprednisolone, which is Medrol, and the beautiful thing is it comes in a dose pack. So it's the easiest prescription ever. You literally write Medrol dose pack, use as directed, dispense 1. It's the easiest prescription of all time. And this is what it looks like when you have it. So I don't know if you guys can read this, but it literally says, take 2 tablets before breakfast, 1 tab after lunch and after supper, and 2 tablets at bedtime. The next day, then it goes to 5, then 4, then 3, then 2, then 1. So it literally tells you how to taper off, and it makes it very, very easy for them. When we talked about how it's really important that patients know how to take their medications, this tells them what to do. So it gives you a nice big loading dose right at the beginning, tapers off. It's nice and cheap. This is a very easy one. Now, you can give dexamethasone in a similar style where you do a big loading dose and then taper off. The problem is they don't come in a pack like this, and you have to rely on the patient knowing how to do it, how to split the pills, all sorts of things like that. You can see first 2 days, 1 tab twice a day, next 2 days, half a tab twice a day, final 2 days, half a tab just once a day. Most people, unfortunately, aren't going to remember all this. This is actually Nate, when he did my surgery on my face, gave me this. The prescription literally comes onto another sheet of paper. It's too big to even be printed on the bottle. I forgot to take a picture for you guys, but I had already thrown that piece of paper away. So this is what's going to happen to most of your patients. Give them the prescription, they'll probably throw the paper away in the pharmacy, not realize how they have to taper it off, and then you'll get a ton of phone calls, or they may just take it every time they have pain, which isn't how the steroids are supposed to work. It is a better drug. It is a stronger steroid. It is more potent, but if they don't take it correctly, what's the point? And then we also can give dexamethasone via injection. So these are what the little syringes we have. We have 1 in each, or the bottles, and then we just use a little TB syringe. We have 1 in each room. You're going to give it pretty much near the apex of the tooth. And I'll use this on patients who have a lot of those pre-op symptoms we talked about, the medical history, the anxiety. If you see that there's a lot of bleeding during it, there's going to be a lot of inflammation. I don't necessarily use this on a case where they've had a bad infection or things like that. You do have to be careful around nerves. So there is some studies that aren't great, but they are there, saying that a direct injection of a steroid into a nerve can actually demyelinate it, which is not a good thing. So I don't give this around the mental foramen. You're going to give 1 cc. That gives the 4-gram dose right next to the apex. And so that's 5 doses. You get 5 doses out of one of these little vials. They are pretty darn cheap is the nice part. So the vial itself is like $8-10, and then I think it's 60 cents for the TB syringe. Actually, I think the syringe is more expensive than that. I think it's the other way around. The syringe is $1.60. Really important, only do this when they are numb. If you are not numb and have ever had a steroid shot given, it hurts like hell. It's so painful. So you want to make sure that they are numb before they do that. Okay. Any other questions on steroids? Daily. Yeah. Oh yeah. No, all the time. Yeah. If I see a patient who comes in and I know that they're going to have a higher risk of hyperinflammation, higher risk of post-operative symptoms, I'm just giving it. Yeah, we don't charge the patient. You can see it adds $2 to the. I would pay $2 for every patient to not have to call me with post-op claims or post-op issues. So it works very, very well. But yeah, we use it all the time, and very, very useful tool to have in your back pocket. But I don't do it on everybody. Like I don't really use it on kids. I don't use it on the big infected teeth. I just use it on those who have a lot of inflammation and who I think are going to be a problem. Great question. Oh my God, yeah. 100%. Yeah. That was actually when I was at the IAE. That was one of the questions I was asked, and I was so confused by it. They're like, aren't you worried that by giving steroids, you're going to mask a flare-up? And I was like, mask a flare-up? Like, stop a flare-up. It's not like it's happening underneath. You're literally stopping it from flaring up, which is exactly what you want. You don't want them to have the pain after. You want them to have a painless experience. So yes, makes a huge difference. In a lot of our patients, I will combine the two. So I'll give them the Dex injection the day of the treatment and then have them start taking the Medrol the next day. I give out a lot of Medrol dose packs. Any other questions on steroids? Cool. I brought this up to one of my buddies in town who's a rheumatologist, and this was what he said to tell all of you. He gives the equivalent of an entire dose pack to his patients to take daily. Not just the 6 pills, but the 30 pills every single day. What we give is such a small amount, it's not going to make a difference for 99% of the patients. You're not going to have the risk of the side effects like you would for chronic steroids. They're not going to get the puffy face. They're not going to get the buffalo hump. All those things are from long-term, high-potency chronic steroid use. We're using this short-term to knock down the inflammation very effectively. Okay, let's go on to the fun drugs. Anytime we talk about narcotics, I do have to bring up that we had, back in 2017, we called it the Jones West Forward Pain Clinic. If you haven't read about this, it is absolutely hilarious. They were literally dealing like opioids out of the back of the service area, and there was like a doctor who was there. It was ridiculous, like literally as insane as you can think it is. And because of this and a few other reasons with Vegas and pain clinics, the governor at the time got really upset, and now Nevada is one of the hardest, most regulated states when it comes to opioids. So I always have to talk about the Jones West Forward Pain Clinic. It's now changed their name. That's how bad it was. But what we've seen is a really nice decrease in opioid dispensing rates. Even from 2019, you can see the opioid dispensing rate per 100 people. Anything, the dark green is over 52.8. So you can see primarily in the South. As we go to 2020, it drops down. 2021 drops down. And then the most recent one is from 2022. And you can see we're still seeing a lot in the South, but definitely overall huge decrease in the amount of opioids that are getting dispensed. And we've kind of touched on that last time as well. A few quick definitions. Opium is from the poppy plant itself. An opiate is any agent derived from opium, so that means it's not synthetic. And then an opioid is any substance with a morphine-like property, which would include the synthetics. If you've never seen how they actually harvest these, they take the poppy plant and they scrape it, and then this right here is what is opium. It's that little milky stuff that comes out. The number one producer is actually Afghanistan. So one of the things that the Taliban did was they stopped all of the production of opium, and then when the United States came in and knocked the Taliban out, you can see huge increase. So kind of a fun little how geopolitics narcotics can impact all of us. As far as the different ones that we use, you can see the chart of all of them. So codeine's one of the oldest ones. Codeine, morphine's a derivative of codeine. Hydrocodone is a semi-synthetic derivative of codeine. That gets you into your Dilaudid, gets you into your all the different ones here. But these are mostly what we're going to be using is the semi-synthetics. The full synthetics are going to be your oxycodones and as well as Narcan. And really, as we talked about, you have your straight derivatives from the poppy. Those are going to be your morphine and codeine. Certain patients, especially of like Scandinavian heritage, don't do well on these. I was in an accident when I was in high school and had morphine given to me. I didn't get any pain relief, and all I had was just severe nausea. And you see that with a lot of tall dudes who look like Kristoff from Frozen, like me. We tend to have more of a response to that, whereas the synthetic ones you can tend to do better with. Semi-synthetics are going to be your heroin, your hydrocodone, and then your full synthetics are just synthesized in a laboratory. That's going to be your fentanyl and your methadone. Now, what we're seeing is a huge spike in synthetic opioids other than methadone because of fentanyl. The reason fentanyl is so dangerous is because these are equivalent doses. So heroin, you can see quite a lot. Fentanyl, it's a very tiny, tiny amount. And then carfentanil, also known as elephant fentanyl, is just those tiny little bits there. This is the equal dose. So what's happening is your friendly neighborhood drug dealer might not be the best with laboratory safety. And so if they're weighing out the drugs on a scale, you can have the fentanyl get mixed into other drugs. And that's one of the ways that we're seeing a lot of these deaths. That's why fentanyl test strips are so important, no matter if you're going out and having fun, if your friends go out and have fun like this. Get some fentanyl test strips. I'm happy to say that back when I gave this lecture a few years ago, both Kansas and Missouri banned them because they saw them as drug paraphernalia. Beautifully, that has actually now been legal, and so you can get fentanyl test strips in Missouri, which is great. I'm sure you guys all remember the death of Michael K. Williams. This was actually cocaine that was laced with fentanyl, probably in the way that I talked about, and that's why it's really, really important to make sure you test if you're going to be doing any drugs. I care about all of you. I know you can sometimes have fun. Just test the drugs. How many of you know how to use Narcan? Braden, it literally tells you how to do it. It used to be prescription only. Thankfully, that is now over the counter, so you can keep it with you. It's good to have just, throw one in your purse. If you find you're not going to hurt anybody. Like if we gave all of you Narcan right now, it wouldn't do anything. If you have opioids in your system, though, it immediately reverses them and you can save lives with this. So no matter where you're going to be, it's a good idea to just have some on you, just in case something goes wrong. Okay, how do opioids work? You guys all remember this back from pharmacology in dental school, but you have 3 different receptors, the delta, kappa, and mu receptors. Delta is going to give you the analgesic, antidepressant, but also the dependence one. Your kappa is going to give analgesia and sedation, and then your mu, this is the one that gives you the euphoria. This is why people get addicted to opioids, is because it hits that mu receptor there. When we're prescribing them, the rules are pretty much the same in all states now. Lowest effective dose, you have to tell them about using it with alcohol. If you are giving a combo drug like a Norco or a Percocet, you have to tell them about acetaminophen. Depending on your state, you have to have a separate consent form. Nevada is one of those, so we just put it in with a slate of consent forms. I don't want to have to do a separate one every time we give it, but I don't really give out a lot. We'll talk about that in a second. If you are in most states now, before you give out an opioid prescription, you have to go on and check and see, is this patient receiving any other controlled substances? And then most states now are going to require extra continuing education as well if you have a DEA license. For Missouri, for those of you practicing there, first thing you have to do is apply with a registration with a state authority. A lot of states are doing this now, so I have to apply to the Nevada Pharmacy Board before I renew my DEA. So just a fun fact, you'll have to check depending on your state. If you don't know what you have to do and you're going to a new state, look up the State Dental Association and talk to the executive director there. They can get you all set up with that. That's why the ADA is there for you guys. If you are working at multiple locations, you want to apply just for like the one that you're at the most of the time. So if I'm here 4 days a week and at another location, it would be for here. The one annoying part is that they are state-based, meaning if you have a practice in Missouri and a practice in Illinois, you actually need to get 2 DEA licenses. When I practiced in California and here, I had to pay for 2. So it's kind of annoying, especially if you're going to like a area where you're going to be in multiple areas or in multiple states. That also applies to where the patient is. So I still see patients from California. I cannot prescribe controlled substances to them in California. They have to pick it up in Nevada. So that might be a consideration if you're going to be practicing near a border, that you may have to end up getting two, switch it out. It can be a little bit annoying. As I said, your state dental society should be able to help you figure all this out. That should be the first. Once you guys figure out where you're going, call the local society. They'll help get you set up. We just did a huge thing helping the students down at UNLV get registered for their license as well. Now, this is what it's going to look like. This is the database that you just create a email, log in. The one that we have looks exactly the same. You can check multiple states. Do you guys have DEAs right now, or are you still using the facilities? I check it on everybody, and it doesn't take very long to quick run through and just see if they've had any other prescriptions, but I know you guys aren't giving out too many. As far as the opioids that we use, there's going to be these main four: Tylenol number 3, Norco, Percocet, and OxyContin. Tylenol number 3 is a garbage drug. It is mostly, codeine is a terrible, terrible, terrible drug. It gives you the worst. It's just an awful drug. Sorry if people out there. For some reason, little old ladies love getting addicted to codeine. Don't know why. The only time I actually saw a Narcan reversal, I was in the ER in Minnesota, and a lady came in, and poor sweet husband didn't realize that she was addicted to codeine. And so the ER doc gives her the Narcan shot. And what happens is when you give them the Narcan, the patient's probably going to be really pissed off because you just ruined their high and put them into instant withdrawal. You also save their lives. But this lady went from being this sweet old, 80-year-old into the meanest, angriest lady you've ever seen, because now all of a sudden she was in the throes of withdrawal. Codeine's a terrible drug. I don't like it. The only time you might use it is it's very readily available in a liquid format. So for certain pediatric patients, but for most of them, they're fine taking liquid ibuprofen and Tylenol. So I haven't given out a Tylenol 3 in God knows how long. Next one's going to be your Norco. This is kind of our first choice. We're going to do a 5 milligrams of the Norco, 325 of the acetaminophen, just dispense 12. That should give them 4 days worth of drugs, 3 to 4 days, depending on how much they take it. And if they need more than that, you probably want to see them back because there's something else going on and something's gone wrong. As far as Percocet, I don't really use it as much, because if I think they're going to be in more pain, I want them to take my ibuprofen Tylenol combo that we talked about last time, and having the 325 in there really messes with the math and confuses everybody. That's why the solo drug of oxycodone is a lot more useful, because it's used in severe pain only. Any questions about opioids so far? You guys won't be really giving out a lot of these. The thing to remember here is that NSAIDs, steroids, they treat the actual source of the pain. They're going to stop that cascade from happening. Opioids are going to treat both the emotional pain associated with it, and they also block the pain signal from actually hitting the receptor, meaning they're not treating where the pain's coming from, you just don't feel it. So said another way, you still have that hurt, whatever caused you to need it in the first place, but you don't care about it as much. And so on certain patients, it is useful. We have to, as part of our registration, we have to review every 6 months the last year of controlled substances we've given out. How many in the last year? So I ran it at the beginning. I always run it at the beginning of the year and right after my birthdays because I remember it. How many opioids do you think I gave in 2024? Take a guess. 0. No, I gave out 3. 2 were on really nasty, large infections, swollen. They came in. And then 1 was on one where the gentle wave had something weird happen, and all of a sudden there was bleeding, and it was really an odd situation. And I was like, I think he's going to hurt. I'm going to give him something preemptively. But that was it. I gave out 190 Halcyon prescriptions, but I gave out 3 opioids the whole time. Make sure you know the requirements, because the penalties can be really, really bad. And what will often happen is you're not going to necessarily have your board come after you. You're going to have the pharmacy board come after you. When the pharmacy board comes after you, then the dental board's going to come after you. We have to take a yearly education course, and the stories they've told about some dentists doing some very dumb things are very common. So make sure you know the regulations, make sure you follow them. They really don't add that much time, and you'll keep you guys safe. As far as how my pain management goes, we always start with the ibuprofen Tylenol combination. We add on steroids as needed, and then opioids are a last resort. And like I said, I don't give out many of those. Okay, muscle relaxers. This used to just be the one, but I have a friend who's giving out a second type, and so I had a long conversation with my lovely wife last night about when you'd want to use one versus the other, and I'm still confused. Why do we use these? It's going to be for TMJ if they're having a lot of issues. So if they kind of lock up, that can be one reason I'll give it after. Anytime you're having a muscle spasm, any type of pain where you think it's muscle-based, a muscle relaxer, a short-term dose is going to be very useful. They can help with clenching and grinding in the short term, and sometimes I found use if you have trismus and you can't get a patient open, the muscle relaxers can oftentimes help because usually trismus is going to be from a muscle spasming, not necessarily a structural component blocking it from opening. The main one that I use is cyclobenzaprine or Flexeril. It comes in 2 doses. You either have 5 or 10 milligrams. It works through the serotonin pathway, and it also has some TCA, the old school antidepressant, like effects. It does take a while for that to kick in, so you probably won't see it though. The nice part about this is you're giving them a good night's sleep. If you've ever taken Flexeril before, it will knock you out. You will sleep. And for a lot of these patients, they've been in a lot of pain, they've been waking up, they haven't had a good night's sleep, and oftentimes just one good night of sleep is able to fix a lot of their problems. So I only give out 5 pills at a time. We have them taken an hour before bed. It's very affordable. I have another good friend who's an endodontist who's been talking about how much he loves Zanaflex or tizanidine. I've always had trouble saying that one. This one works via being an alpha-2 adrenergic agonist. And the nice part about this is you can give a higher maximum dose. The downside is it has a shorter half-life. Both are still going to cause sedation. The kind of summary that we came out with is if you're going to be giving them for chronic, tizanidine is better. Cyclobenzaprine is only for acute use. You're not supposed to take it more than 2 months. The other thing is both of these, you do have to be careful because the heart is a muscle. It can interact on those. So if they have anything like AFib or anything that revolves around the heart itself, you want to avoid that. Tizanidine also has some pretty gnarly interactions with a lot of the heart medications like amiodarone or the other like big scary heart medications. So you want to check that before you were to give it. The one thing that tizanidine is able to do, this is the Vanessa's beautiful pink cheat sheet for me. The Flexeril is just antispasmodic, whereas tizanidine is antispasmodic and antispastic. So antispastic is you have a disruption in the muscle movement pattern itself, and this is usually from damage like MS, sciatica, things like that. Antispasmodic is more for myofascial pain, musculoskeletal, things like that. So both drugs work. I'm more confused than I was when I talked to her last time. I think I'm going to keep on using the Flexeril because I didn't see any good reason to switch over to Zanidine, but I wanted you guys to know what's out there. Do you guys feel more confused than when we started? Any questions on muscle relaxers? Go ahead. You know this stuff so well, is that what you said? Right? Oh my God. Seriously. All right, let's finish up with benzos here. So, do you guys want to take a picture of this? This is kind of your cheat sheet. I can also send you this if you want. But here are all the benzodiazepines you're going to really see in dentistry, your generic names, your trade names, your dosing, time to onset, and half-life. You'll notice one of these things is not like the other. And that's why I love this drug. And we use a lot of triazolam. So we're going to go through all of them. Starting off with Xanax, we don't really use it a lot in dentistry because it lasts for a long time. Most of the time, the patients are going to get this from their MD and come in already on it. So I don't really give out this prescription unless they said, oh no, I've had Xanax, it works great for me. If somebody has told you, hey, this benzodiazepine works really well for me and I've used it in the past, go ahead. You know that it already works. Get the dosing. You can usually look it up on the because you have to look up for these too, by the way. These are, even though they're not the same level of control or they're not, the narcotics, you still have to look up if you're giving out a benzodiazepine. But as far as sublingual versus swallowing it, what the studies show is that if you put the pills sublingual, it tends to kick in about 15 minutes faster. So I tell my patients to do it just so that they don't have to be waiting forever for the drug to actually take effect. It's also nice for kids because they might not necessarily want to swallow the pill, but they can all put it underneath the tongue. Valium, old school drug, it has like the longest half-life ever. And I don't know if you saw that, it was up to 300 hours for the half-life. Meaning, if you give this to them, they might still be hungover multiple days later. So not really what we want to have, but it's something to consider there. The really nice part is it is available in a liquid form for kids, and a lot of the pediatric dentists I've talked to say that kids tend to do better on Valium than the other ones. I usually use Halcyon when I sedate kids. You may may be using it, but I wouldn't really use it on adults just because you're so destroyed for so many days after. Ativan is a very useful one. It does take a little bit longer to kick in, so you have to give it 2 hours before the procedure. But when I'm giving Ativan, it's usually because they've already been on a benzo, so they're like taking Xanax daily for anxiety, and they need something a little bit more. Now, the big question is always, do they have to stop their regular dose? And the answer is no, because they've become accustomed to it. So that whole like, oh, I can't give, a benzo and an opioid, that is totally true if they haven't had either of those. But if someone's on like a pain management program with, methadone or something like that, you can still give them the benzodiazepine because they become accustomed to taking that narcotic. And so you're not going to overdose them because that's their usual just state of being. Same thing with the Ativan. If they're already on a regular amount of, Xanax daily just to function, the Ativan tends to work a little bit better. And then finally, triazolam. This is my preferred option. Great, great, great medication. It's nice because it kicks in really quickly and it has the most amnesia of any of them. It also has the lowest rate of respiratory depression. If you were to try to, off yourself using any benzos, most of the time, as you don't have anything else in your system, it's impossible. You could take a whole bottle worth, 100 tablets of triazolam. You're gonna have a great sleep, and you will probably wake up 3 days later feeling pretty terrible, but you will still be alive. If you add on alcohol or opioids, then it all goes out the window. So when we talk about this with patients, you make sure they don't take anything extra. And I'll talk about that in a little bit as well. The big ones are alcohol and opioids. If you live in a state where medical cannabis or recreational cannabis is legal, sometimes patients will want to take it with it. And I will tell you, it is not good at all. I had one patient come in, they had taken an edible as well as the Halcyon, and they were crawling on the ceiling. They lost their mind. We weren't able to do anything because they were losing their minds so much. So when we talk to patients, if they have a history of using cannabis for whatever reason, I always tell them that story and say, do not take it with it. It's a terrible experience for everybody. With the elderly, they're going to process this drug differently. You're going to want to decrease the dose. And the way we tend to do that is based on both the level of anxiety of the patient and kind of their history with the medication. So if you have a skin and bones 75-year-old who's just kind of slightly anxious, maybe just use 0.125. You can always reappointment him if it's not going to be enough. If you have a big, heavy dude who's crying when you walk in the door, you can still up it up to the regular dose. So be careful with the elderly. On kids, I tend to vary my dosing both on the age as well as the weight of them. So if they're over 100, they can generally have the full adult dose. If they're less than that, I'll oftentimes decrease it. And then you also have to see how they are. So for every pediatric patient, I don't do any meet and treats. I only do consults first. There's a big difference between the kid who opens your mouth, lets you look at everything, and the one who's doing this and looking around all the time and trying to see what you have and starts crying when you put the mirror in the mouth and opens this far. They're going to need more sedation. The other thing is for pediatric sedation, your legality is going to vary based on your state. And so sometimes they'll define it as 16 as younger, sometimes 12 and younger, sometimes 18 as younger. And then it just depends. You may need to have additional training and licensing. You do have to be careful with polypharmacy, and this does include nitrous. So state laws, if you have more than one sedation thing on there, and that can include nitrous, you could require a sedation. So I don't use nitrous when I have the Halcyon. Usually the Halcyon's enough. Any question on benzos? That's a good, if you have the doctor give it, yeah, that's a difficult one because who's liable is the situation there. And, we run into this if the patients are like, oh, I had some Xanax that I took before I came in. Well, do we have to caution them about driving? What do you have to, there's some rules when it comes to these sorts of things. So usually we tell them not to come in on anything unless we've prescribed it. Because it's a kid, I think you're making the right call. If it's an adult who already has a driver, they're given Xanax from their, medical doctor, I'm not going to not see them like they've had it before. But I think you made the right call with it being pediatric. If you're going to be doing that, right now you guys are in a safe environment to be able to do it with a pediatric residence. Keep doing it like that. When you get out, this is where it gets a little weird, and it depends how comfortable you feel treating kids. And really, it's how comfortable do you feel treating the complications if something goes wrong with the sedation. That's a question that all you have to answer on your own. I think you made the right call saying, no, I don't want to take this on, even if somebody else prescribed it. Good question. Any other questions on benzos? Now, there are some other drugs the patients may come in on. Mostly it's going to be either alcohol or cannabis. And the question is, what do you do? Well, this is actually the only paper that I published. Back in in dental school, I worked with a few different people at the school, and we published a paper on what to do if the patient comes in either having consumed a little bit of alcohol or consumed a little bit of cannabis. And really the answers are, with alcohol, it is going to interact with some antibiotics, obviously with opioids or with benzos. There are some concerns about, can they give informed consent if they're inebriated? Who's driving? The general consensus was, if it's, oh, I had a beer at lunch, you're probably okay to still treat them. If there's little danger to the patient, it's fine. If they come in wasted, obviously that's when you're going to postpone it. You're not going to be able to really say we gave them informed consent. They're not in the right mindset. So that would be where you'd want to kind of move off. For THC, there's a few different issues, because how do you figure out the dosing? Now that we have it more legal, obviously it comes in different packs or whatever, and different, but there's a huge difference between strains. There's a huge difference between the method of how they, is it swallowed, is it smoked, is it vaped, whatever it may be. The big side effects here, some are great. The xerostomia and analgesia are fantastic. In certain patients, it can give them some sedation and help with anxiety. In other patients, it can give them panic attacks. So that's not great. With both THC and alcohol, it will cause some tachycardia, so you do want to check the blood pressure, make sure that it hasn't increased and that the heart rate isn't, crazy high. As we talked about, do not use with benzos. We have the same issues here of, can you give consent and can they transport? And I think it depends on kind of how they act when they come in. But if the heart rate is normal, they seem to be in an okay place, it's okay to treat them. Other random prescriptions you might give out, ondansetron or Zofran, is if they know they have an issue with narcotics. It's an anti-nausea medication. You give it with it. It's a very easy prescription to give. You give out, if you give out 12 opioids, give out 12, Zofrans. Pretty straightforward there. All right, quick quiz time. What is this and what is this? So we'll take the up on the maxillary. What would you give for this right here? You give what? Magic mouthwash? Okay. What is this? Aphthous ulcer. Very good. What's the difference between herpes and aphthous ulcers? Attached mucosa. Very good. Herpes is going to be a virus, and it will only be on the attached mucosa. It's going to be known also as a cold sore, is how patients will refer to it. This is an aphthous ulcer. It's caused by the immune system, and they call it a canker sore. So the treatment for these are both very different. If patients suffer from recurrent herpes virus attacks, valacyclovir is going to be your best friend. I give them a bunch of it. I'll give 30 pills. I give lots of refills, because this is really a common thing. For a lot of patients, they're going to have a prodrome. They'll all of a sudden notice that there's tingling or something going on inside there. And if they take it immediately, they're not going to have it pustle up. And so it's 2 grams, one in the morning, 1 at night for 1 day. You're good to go. So that's why we give 30. I give lots of refills on these, because patients know when they have, oh, I'm going out in the sun. Oh, I'm having a dental appointment. It also is useful if you're trying to figure out some weird mouth burning things. If you're doing more of the oral medicine side, sometimes it's actually a virus that causes it. So I've seen a few CE things with oral medicine where they end up giving Valtrex or some other antiviral, and it actually fixes a lot of the issues as well. Okay. The final one is betamethasone dipropionate augmented, and this is a very high potency steroid. You're only going to use this short term, and pretty much you apply a pea size to it. It is expensive, but for patients who have chronic aphthous ulcers, this works extremely well to knock it down very quickly. The steroid helps calm down the effect, and it kind of burns the area. When we have an inflammatory ulcer, what you want to do to make it heal a lot faster is change from an inflammatory ulcer to a traumatic ulcer. So if you guys ever suffer from one of these, there's an easier way to do this, which is take your toothbrush. You're going to hit it without toothpaste on the spot for as long as you can stand it. It's going to hurt like hell, and the next day it'll be gone. Anytime I get an aphthous ulcer, this is what I do. It sucks when you do it, but it's gone the next day. So if they don't want to spend, it is expensive for any of the dermatological medications. So it is, I'm not sure if you guys saw that, it's like $55 for that tube. So it's not cheap whatsoever. This is a great way to do it, but it does hurt a lot. And so if you have an electric toothbrush, it's free too. A little bit on antifungals. We're not really seeing too much of this in endo, but There's going to be 3 main ones that we give. Mycostatins, or nystatin, is the oldest one. It's going to be for denture stomatitis. Fluconazole is more effective for candidiasis than nystatin, so you're going to want to give it for that. And then if you have angular colitis where you have the spots on the side, miconazole is going to be your best, and that can actually be, you can even have the tinactin, the over-the-counter one. They can use that. So for old patients who have had like a collapse of VDO and they start to have angular colitis, you can tell them just use the tinactin. It's over-the-counter. It's a lot cheaper than giving a prescription. Finally, this is triamcinolone or kenalog and orabase. We don't know how it works, and this is what you give when you don't know what's going on. I know that sounds funny, but when we were in residency and had patients with weird stuff in the mouth that wasn't anything obvious, you give this, and if it works, fantastic. If it makes it worse, you know that it's either a virus or an infection or a fungal because it's a steroid. So keep it in your back pocket, useful. Chlorhexidine, you all know about this. We use it post-operatively after any surgery. There is some new evidence coming out that it actually kind of slows down healing. It's also pretty broad spectrum and can kill some beneficial bacteria inside the mouth. And there's some new studies showing that it can actually kill the ones that help with nitric oxide production, which can lead to temporary hypertension in a patient. And it can also mess up some of the bugs that help with gluten digestion, so it can actually increase gluten sensitivity. So we're kind of moving away from that. The ones that I use now is something called Stella Life. There's some, I've talked to a few periodontists with this. I've used it now. I've switched over probably last summer. We switched over and haven't seen any difference between chlorhexidine and using this stuff. So it seems to work out pretty well. But yeah, a lot of the periodontists are dropping away from using Paradex as well, mostly for the healing, but also because of the broad spectrum stuff. So interested to hear what the periodontists are doing now at SLU. This is the other stuff that they're using. It's this antioxidant dental gel. I had this done when I had, Nate gave me this last time I was there. So there are a few different things you can use besides that. As far as my top prescribed medications, steroids are number 1. Triazolam, amoxicillin are super common. Zithromycin, clindamycin would be my next ones. Flexeril is super common as well. Not giving out as much Paradex like we talked about, and then not really giving out a ton of Norco or Zofran. And I really don't use Augmentin Metro too much because of the cost and side effects. Most of the time, this is able to take care of all my infections, but every now and then have them in your back pocket. So that is pretty much it as far as pharmacology. I'm gonna go ahead and stop sharing. What questions do you all have? What can I answer for you? I know we're a little tight on time here. I don't know if my next one's here yet either, so. Any questions? Oh, great question on anesthesia and if they've come in high. Yes, that is, especially if they're like chronic users. I've seen that they're harder. I don't really have too many who come in high. Like they don't decide to come in, already having consumed something. So I don't have a big number for that. But if they are someone who uses cannabis like recreationally constantly, they are a lot harder to get numb. Not sure the mechanism of action on that one. One of the issues with it still being labeled as a Schedule 1 drug is you can't actually do any studies on it cheaply. So that's why we don't know a lot about, what happens with weed. But totally agree there. If it could be an anxiety-based thing, and if that's the case, then Halcyon would be useful for those cases. But you want to make sure they don't come in on the drug either, because that would be bad. What other questions do you have? Hopefully this was useful. You'll give out a lot more steroids, antibiotics than anything else, but I wanted to I felt like this wasn't something I really had the whole point of me doing this is what I wish I knew in residency, and I'm trying to tell all of you what I wish I knew in residency. You guys have a great pharmacological background from dental school. You won't use most of it. These are the drugs you're actually going to use. Cool. Any other questions? Nope. Oh, don't apologize. You're fine. We're timing wise, we're still good. So I'll text you guys the links to those YouTube videos on starting a practice. Let me know what you think. Regardless, we'll cover a PE next time and kind of most of you are going to end up working for some office that has some influence with private equity. So I want you guys to all be prepared. And then if you guys want me to go back and do the how to start a practice, we can do that. Otherwise, I'd rather go into the how did most dental practices screw up and what can we do to make it better. Cool. Have a good one, guys. All right, I'll see y'all later.